The Jerry Powell podcast is brought to you by Archstone Foundation, preparing society and meeting the needs of an aging population. And now, here are your hosts.
Welcome to the Jerry Powell podcast. This is Eric Wadera.
This is Alex Smith in home quarantine. Well, I'm not actually in home quarantine. I guess I'm in...
You are social distancing yourself.
I'm social distancing. I'm, what do we call it? It's not lockdown.
Shelter in place.
Yeah, I'm in shelter in place. That's what I am.
And because this is going to come out a little while from our recording, this is March 18th. We are still kind of in the middle of the pandemic. Hopefully going to prevent the surge. We'll see what happens when we actually get this published out. But we have a special guest with us today.
So we have Laura Petrillo, who's a palliative medicine investigator at Massachusetts General Hospital in Boston and Harvard Medical School. And Laura's been on our podcast previously when she was at UCSF as a palliative care fellow and then as a research fellow. Welcome back.
Thanks so much for having me, guys. It's great to be here.
So we're going to be talking about a really important topic in both palliative care and in geriatrics. It's immune checkpoint inhibitors. We're going to learn a little bit about them, but importantly, we're also going to talk about some of the outcomes that Laura has done some great research on with an article that was recently published in Cancer titled Performance Status and End-of-Life Care Amongst Adults with Non-Small Cell Lung Cancer Receiving These Immune Checkpoint Inhibitors. We'll have a link to the article on our show notes, but before we dive in the article, we always ask for a song request. You got a song request for Alex?
Yeah, actually, I was thinking about Radiohead, No Surprises.
Okay. And this has got like the most depressing lyrics I've ever sung on the Jerry Powell podcast. Can you share with us why you chose this song?
I think part of what we'll talk about eventually is just that it's helpful to know what's coming with any therapy that you embark on. And so one thing that I think hopefully this paper and other kind of real world evidence will start to show is that there are some unanticipated kind of risks or burdens to treatment. And so in any good kind of informed consent, risks, benefits conversation, there shouldn't be any surprises. So
no surprises.
No
okay.
surprises. Yeah, it was not quite as dark as the lyrics would sort of.
Great. Here we go.
Tired, unhappy, bring down the government. They don't speak for us. I'll take a quiet life, a handshake of carbon monoxide, no alarms and no surprises, no alarms and no surprises, no alarms and no surprises.
I miss you in my office, Alex. I can't control your mix here. Yeah, I promise I won't actually insert the real Radiohead version. So Laura, immune checkpoint inhibitors, like how on earth did you get interested in this subject?
So immunotherapy, which is just kind of the whole class of medications that use the immune system to fight cancer, is a kind of new paradigm of cancer treatment, incredibly important, transforming the landscape for so many different types of cancer. And so just as a palliative care clinician, currently I mostly care for people who have cancer, and just seeing people live longer, have really different outcomes with immunotherapy than with traditional chemotherapy. And yet I also noticed that there were differences in some kind of end of life experiences that people were having, and wanted to just see what we could see in the data and explore a little bit about what is happening for people who are not typically represented in clinical trials.
And can I ask you, when you embarked on this, kind of what were you seeing, kind of boots on the ground, as far as any concerns or differences?
Yeah, so people who may be familiar with immune checkpoint inhibitors and immunotherapy, from seeing it in the news, Jimmy Carter getting immunotherapy for his cancer and having a wonderful response, and others, and a lot of things in the media, just of these incredible stories of people having good responses to immunotherapy. But one of the phrases that was sort of bouncing around clinically was, no one dies without immunotherapy. And that was because, in contrast to chemotherapy, which, cytotoxic chemotherapy, which can be so toxic with so many side effects at the end of life, when you're thinking about risk and benefits and kind of framing those conversations, there are these really clear trade-offs between feeling worse with the hope of gaining some more time versus focusing on quality of life. And I think that when these agents sort of first started to come out with, some incredibly hopeful outcomes for a subset of patients and in certain types of cancers, there was the feeling that, they're better tolerated. They have a whole range of bananas side effects, which we can talk about separately. But at the outset, they seem like they're better tolerated in general. And so the feeling is kind of, why not? If someone is otherwise, either not in shape to receive chemotherapy, they've already received chemotherapy, to hear something that is kind of better tolerated, what is the harm in trying one of these, potentially a miracle agents for someone who would otherwise be transitioning to hospice? And so immune checkpoint inhibitors are there are different indications across different cancer types. They're most widely used in melanoma, lung cancer, head and neck, renal cell cancer. There are a handful of cancers, but they're varying in terms of how successful they are. They're very successful in melanoma and lung cancer. They've been helpful and widely used. So when they were first approved for lung cancer, though, they were approved in that second line setting, so previously treated patients. And I think that affected that attitude about trying them prior to making a transition to comfort-focused care.
Can we, taking a step back, can you describe for our audience, some of whom may have heard of immune checkpoint inhibitors or immunotherapy, some of whom may not, what is an immune checkpoint inhibitor in sort of really lay terms?
Sure.
And what are some examples of drug names they might be familiar with? Absolutely.
So in general terms, the way that immunotherapy works is trying to get the immune system to be activated to fight cancer. And so in general, when the immune system sees any type of invader, like a bacteria or a virus, it's activated to recognize not self. But cancer cells typically sort of shut that off the same way that our own self cells shut that response off. And so immune checkpoint inhibitors inhibit that inhibition of the immune system. So they say, immune system, come on over, attack the cancer cell, because that kind of little shield is no longer up to protect the cancer cells. They inhibit the pathway that is inhibiting the immune response. And so that is partly why we get those really crazy immune-related adverse events, the kind of side effects of checkpoint inhibitors, because the immune system is activated and then can attack other tissues in the body.
Can you tell us some of the common side effects that we should kind of know about in both geriatrics and palliative care?
Yeah, absolutely. So interestingly, the most common side effects are very nonspecific. So they're like fatigue, nausea, but then there are very important side effects like pneumonitis, which is inflammation in the lungs, obviously, and can cause serious respiratory problems, colitis, so attacking the gut cells and causing bloody diarrhea, and rash is common. But then there are these even more kind of toxic side effects like myocarditis, which can have a high fatality rate. So most of the fatalities from immune checkpoint inhibitors are from kind of some of the more severe immune-related adverse events like myocarditis and pneumonitis. There are some other wild ones like neuro side effects that can attack the neuromuscular system, and so can cause side effects that can be paralyzing. And so and transverse myelitis. I've seen a lot of kind of crazy things. So basically any system in the body can be attacked and cause side effects that sometimes will mimic known autoimmune diseases. But sometimes are entirely new phenomena, and we're actively learning about them now, kind of in real time with patients. There are some that were observed in clinical trials, but there are certainly more that are becoming more clear as they move into prime time.
And what are some of the common medications or drugs, names of these immune checkpoint inhibitors that our audience might be familiar with?
Yeah, absolutely. So pembrolizumab is one that's used commonly in lung cancer that we will talk about, often used in combination with platinum doublet chemotherapy. And then the nivolumab is another one, ipilimumab. So you might hear Ipi and Nivo. They have these like cute little short names, Ipi, Nivo, Pembro.
That's great because I never know how to actually pronounce these.
Yeah.
It ends in mab. That's the key.
It does, but that's not that's not specific. There are others.
Right. So there are other drugs that end in mab that are not immune checkpoint inhibitors.
Yeah. But the ones you'll see the most often are nivolumab, pembrolizumab, ipilimumab, atezolizumab. Those are some of them, but they're still
terrible.
more.
Those are the generic names.
Yeah.
What are the brand names for these, just in case our audience have heard of some of those?
Yeah. Yervoy, Opdivo, and Keytruda.
Keytruda, the commercials for Keytruda.
Yeah, exactly.
I think all the MABs are monoclonal antibodies. And then,
that is true.
And then you kind of go from there.
Yes, but not. I guess not all MABs are checkpoint inhibitors. Yeah. So the checkpoint inhibitors are either the PD-1 inhibitors or CTLA-4. So they're both working on that pathway that is helping the cancer hide from the immune system or stopping the cancer from hiding from the immune system.
That's great. Anything else by way of background that we should know about immune checkpoint inhibitors?
Yeah, I mean, I think that the main thing to know is just that in settings like melanoma, for example, they are just having such a drastic effect on survival. So metastatic melanoma survival after a diagnosis would be kind of less than a year. Previously, when we were sort of in the pre-immunotherapy era. Now, there had been IL-2, which actually also worked by affecting the immune system, but it was not very well tolerated, so it wasn't used a lot. But when immune checkpoint inhibitors came along, we now have patients living years. And for some oncologists, we'll even use the word cure for people with metastatic melanoma. So it is a huge difference. And it doesn't, those kind of results don't happen for every patient who receives these drugs. But the hope of that kind of long-term, I use the word kind of durable response as opposed to cure, because I think that we're still sort of learning. But there's just that hope that, that will be the miracle drug. And, I kind of, I'm on some Facebook groups of patients talking about these drugs, and they're so excited and so thrilled with the kind of long-term response they've had. And I've had plenty of patients too, who just are living, they didn't expect to live to their daughter's high school graduation, and they're living to college graduation. And it's just, they don't even know, it's just so incredible. So there's a huge amount of optimism. And I think that it is very much warranted. And these are really exciting drugs that are transforming the landscape, and combinations are coming out, and ways to make them even more effective, and other ways to use the immune system to fight cancer, that are different kinds of immunotherapy that are the hype and enthusiasm, I think, is really is warranted. I'm a believer, but I think that just from the supportive care point of view, there's a lot to understand. And there's also a lot to understand for kind of all adults, not just the ones that are in clinical trials. So that's why we set out to do this study.
Yeah. So it's a good segue to, we're seeing a lot of people get this, even people with exceptionally poor performance status. And how do they actually respond to these new treatments? Do you want to tell us a little bit about kind of what you did in this study, kind of sum it up as far as who was included and kind of the methods of it?
Sure, absolutely. So in clinical trials, as you know, they'll usually limit participants to people who don't have a lot of comorbidities and who have good performance status, which is, the oncology lingo for functional status, who just are not limited in their activities of daily living or in their amount of activity in any way. And so it's not an entirely representative population, particularly of previously treated patients with cancer. And so in our study, we did what kind of a real world study. It included all people who had received immune checkpoint inhibitors over a period of time, over about 2 years, and just looked at their survival outcomes, so the length of time from the time that they received the checkpoint inhibitor. And then we also looked at some other kind of end-of-life healthcare utilization outcomes. We included people who had, every performance status level, as opposed to the clinical trials, which are limited to performance status 0 or 1. Performance status for living people goes all the way up to 4. And so usually people with worse performance status 2, 3, 4, certainly 4, but 2, 3 even, are limited in receiving chemotherapy.
Can you remind us what performance status of 2 or 3 or 4 would look like?
Yeah, absolutely. So performance status 2 is no longer working, up and about, greater than 50% of the day. I mean, these are kind of how these things are graded, and they're clinically determined by the treating clinician. There's huge kind of variability person to person and between patients and clinicians and how they gauge performance status. And I would say in general, clinicians probably round down a bit with the performance status levels to justify treating patients. But
so round down meaning like closer to 0.
Giving people the benefit of the doubt, and I think I definitely assign no ill will to that. It's kind of giving people the chance to get treatment. But
performance status of 2, you're saying would not be eligible for a clinical trial, and you just described that as somebody who's if they are working, if they're working age, if they might not be working anymore due to their illness. And they might still be getting up and about and taking care of themselves, doing their activities of daily living.
The light work was 1, and then 2 is self-care, but no work activities.
And for those who want to look at the ECOG, we'll put up a ECOG up on our website too, so you can see the difference between 1 through 4. 5 is the simplest one, which is dead. I've never actually seen somebody code as 5, but I guess people do.
Yeah, it's not usually at the top of your mind when that's the setting you're in. But
and you looked at the difference between performance status on the ECOG of 0, 1 versus greater than 2. Is that right?
Yeah, and we did sub-analyses of ECOG 2 only because there's a lot of interest in that particular group. I think that people feel less strongly about 3 or 4 treating them. I think you can make a stronger case for kind of comfort-focused measures in general, but PS2 in a place where you might be worried about giving chemo, but thinking about another drug that could be better tolerated, that's sort of, you really want to think about risks and benefits carefully and of course, preferences.
2 doesn't sound, I'm just trying to convert these into, patients I've seen or, disability scales I'm more familiar with from the sort of geriatric side of things or a palliative performance scale. 2 doesn't actually sound all that disabled, quite frankly.
Right. And I think that, working is a hard thing to use. There's plenty of reasons not to be working, but this is, assuming that activity limitation is due to cancer and cancer symptoms. But it's the main thing that that oncologists use and that is used in these clinical trials. So that's why that was what we included. And we wanted to include this group that comprises a large proportion of people who have metastatic cancer and who are being excluded and who are receiving these drugs and kind of receiving counseling from their oncology team potentially about what their survival might be like, but that is kind of gleaned from a different group.
Mm-hmm.
All right,
and it looks like in your study, you had 35% of patients who had a performance status of 2 or greater would not have been enrolled in a clinical trial.
Mm-hmm. Exactly. Yeah.
And about 5% with an ECOG of 3. And these people can are capable of limited self-care, but mainly can find a better chair for more than 50% of the day. So about 1 in 20 are receiving this in your sample. So again, 5%.
I think there is some survival bias present here, because you can think that people who kind of got through their first round of chemotherapy or first line or two of therapy and who haven't made an option to kind of transition to comfort focused care, there are certain people who would kind of make that transition prior to thinking about another line. So that is a consideration, that there's a bit of survival bias in the previously treated group.
Well, what did you find?
So when we looked at survival according to performance status, one more kind of side note before we go there is just that it can be hard to tell the difference between kind of the prognostic and predictive significance of performance status or functional status generally. Because if you take all comers who have these different levels of performance status and you follow their survival afterwards, it's like, similar thing happens with age. People are just going to live less long. I mean, these are independently predictive of survival, right? Mm-hmm. So, doing that on its own, just saying that the survival, what we found ultimately was that they lived less long, like punchline, they lived less long. And I can give you the numbers in a second. But what we were unable to do, which would have been great to do, but we were unable to do because of the way that, this was a retrospective cohort study, is be able to say among people who had an ECOG performance status of 2, if they had a checkpoint inhibitor versus didn't have a checkpoint inhibitor, how long would they live? And that would give us some insight into the predictive value of the performance status in this outcome. But we don't have that ability. We didn't do a randomized trial. We did a retrospective study. So we know that it has prognostic significance to have a worse performance status. And so what we found was that among people with performance status of 0 or 1, the median overall survival, so if you took the curve of patients, the middle of that curve was 14.3 months in the performance status 0 or 1 group. And in the performance status 2 or greater group, it was 4.5 months. So really different. If you look at the Kaplan-Meier curves, it just is a really different shape, drops off a lot more steeply for the PS 2 or greater group.
Mm-hmm. So I guess the point here is that checkpoint inhibitors are not some miracle drug for patients who have some degree of disability and non-small cell lung cancer.
So I think that one thing to just keep in mind is we don't know, what would have happened. We don't have the counterfactual of what would have happened with these patients if they hadn't received it. And we also, the median overall survival is the median. And so there are some patients who lived a while. And I think that one thing another thing that's important to note, there's so many kind of caveats and backgrounds to give here, but for all checkpoint inhibitors, whether or not checkpoint inhibitors will be successful, at least in lung cancer, can be predicted somewhat by the presence of the receptor. So PD-L1, the receptor for these, that indicates that the tumor might be sensitive. And so that predated, or this study kind of predated the widespread use of the PD-L1 test. So it may be that there's a subgroup that does well here that might be indicated by having the presence of PD-L1. And it may be that, without these, people did worse. So what we can say clearly is that people with worse performance status don't exactly do as well as the people with performance status 0 or 1. So you can't just extrapolate those clinical trial results when you're having a conversation with an adult with functional impairment.
Well, I'm gonna push you, Laura. Having done this study and getting the results that you have, does it inform what we should do maybe differently in either geriatrics or palliative care when we're caring for individuals who maybe thinking about starting these medications or are on them?
So I think we need to move to the second part of the findings, because I think that is an important piece to inform that conversation. So part of what I was curious about from my clinical experience was, if proceeding with this idea of no one dies without a checkpoint inhibitor, is there an opportunity cost in terms of the conversations that people are having about end of life, their preparation for end of life, how they're kind of receiving their care, and whether they've made, transitions and how that care is being delivered. And so we looked we first looked at kind of the proportion of patients who were receiving checkpoint inhibitors very close to the end of life, because just with the precedent of kind of chemotherapy in the last 2 weeks of life and in the last month of life being a real indicator of kind of high utilization of healthcare at the end of life, we know that correlates with, increased death in the hospital, increased hospitalization, decreased kind of hospice and comfort focused care. So we looked to see if the same was true here. If people who got checkpoint inhibitors close to the end of life also had differences in the end of life care that they received. If this sort of Hail Mary approach to kind of end of life treatment forestalled any of that type of care that not every person believes that that's the optimal type of care, but if it did in general delay that type of end of care. And we found that patients were kind of less likely to receive hospice care, that they were more likely to die in the hospital, and they were more likely to have been hospitalized in the last month of life than people who didn't receive checkpoint inhibitors in the last month of life. So it was similar to chemotherapy, something that affected the end of life outcome. And I mean, I think that it makes sense. It's logical. People are receiving checkpoint inhibitors. They may have one of these crazy side effects, or you may have heightened suspicion for one of those side effects. And so, something that might be a symptom of cancer progressing, or just a cancer-related symptom, might, in a time when we're trying to understand and learn more about these immune-related adverse events, might prompt admission to a greater degree. So people were hospitalized more often. They, in fact, did experience these side effects, and I think that was a reason for some of these hospitalizations. And just the other thing to know is that it takes a little while to have a response. You have to kind of get the immune system going. And for people whose cancer was on a timeline to be close to the end of life, and you don't necessarily have that time for the effect to work. So you never really know when you see a patient in front of you how long they have, but functional status is one of our best clues, right? So you think we've got these patients who have kind of worsened functional status, and they may be close to the end of life, and it's not totally benign necessarily to give them a checkpoint inhibitor, only in the sense that it might delay some of the kind of transitions in care that would help people to avoid burdensome end-of-life interventions and have care that's more focused on quality of life at the end of life.
Mm-hmm. How expensive are these?
Expensive. Yeah.
We're talking
tens of thousands of dollars. Yeah. And typically given as an infusion once every 2 to 3 weeks. Yeah.
2 to 3 weeks. Yeah. So incredibly expensive medications. It'd be hard for a hospice to justify paying for one of these medications because it would cost them so much money. It would mean they had to make trade-offs in terms of other services that they could provide for patients.
Yeah, and I think there are other settings where my general interest is kind of novel cancer therapies and kind of supportive care and palliative care for them, and particularly helping people sort of understand the risks and benefits and understand their prognosis in the setting of these. So I think a lot about targeted therapies as well in people who have cancer that's kind of like addicted to an oncogene. And in those settings, actually, some of the oral targeted therapies can be actually really palliating, and kind of the idea of continuing them into hospice makes so much sense.
And those are like pennies, like morphine. Those are really
they're pennies. They're not pennies at all. No, they're expensive too. But I actually see a different case for those because actually continuing them even beyond progression can be palliating and can alleviate symptoms. Whereas here, you're kind of going for this. It's like a gamble. There's not a guarantee that you're going to have a response. You have like maybe I don't know, a 20 or 40% chance of having a response at all. And then if you do, it's hope for this kind of long-term response. And so the thought had been, give it a shot, see if it works. I mean, there are very incredible stories of people coming into the hospital. One of our oncologists has this story about a person coming in with kind of metastatic melanoma with leptomeningeal disease and getting, a dose or two of checkpoint inhibitors and like walking out. I mean, there's just really incredible kind of rising from the dead sort of stories about these drugs. And I think that if, particularly if clinicians have seen them, they're really hesitant to withhold anything like that. Patients have heard about it in the news and they're interested in it as well. So, I mean, I think that I totally understand where the interest comes from, but I think that what is important is to have full knowledge of these potential kind of trade-offs between the potential benefit, giving that roll of the dice to see if you have that effect versus kind of what other things could be moving towards preparing for end of life.
Mm-hmm. I have two more questions. The first is, you mentioned targeted therapies and distinguished them from immunotherapy, immune checkpoint inhibitors. Mm-hmm. Could you just give us sort of a lay understanding of what targeted therapies are and how that's different from immunotherapy?
Yeah. Sometimes, and just as a caveat, because there's so much lingo, sometimes people will say that immunotherapy and immune checkpoint inhibitors are targeted, which is very confusing because they are targeting the PD-1 pathway and the kind of immune response. But in general, targeted therapy seems to be used more for drugs that specifically target overexpressed oncogenes or oncogenes that are driving cancer growth. So examples would be kind of BRAF in melanoma or EGFR, ALK and ROS1 and other oncogenes in lung cancer. So this is where there's just a clear gene that has been mutated or copy number kind of increased so that there are or rearranged so that they are that gene is really driving the tumor growth. And then the drugs that target that just shut it down. So they work in a different way. They're really specific, and that's why they're called targeted. They're really specific for their target, and they do have side effects, although kind of particularly in lung cancer is what I'm most familiar with. Some of the newer generation are better tolerated. But they're oral drugs. They still expensive, still fancy, but it's different. Immunotherapy, the class of immunotherapy includes immune checkpoint inhibitors, but also includes things like CAR T therapy and TILs, like tumor infiltrating lymphocytes. So there's just a different class of cancer treatment.
Laura, can I ask you one last question from my end? I think Alex said he had one more question. Now, you did this in an academic medical center. I can only guess which one, which probably also had a lot of access to palliative care for these folks.
Yes.
Do you suspect that maybe if you went into other, again, it's so hard because it's a very specific type of academic medical center where a lot of people go to from other places. Do you suspect if you looked elsewhere, you'd either see worse numbers as far as hospice use and those types of things, or better numbers? Like how should we think about generalizability of your findings that you saw here?
It's a great question. So one thing that sort of tips off what our end-of-life experience is like here is just the hospice rate. I mean, there was just, compared to the national average rate, a really high rate of just hospice referral in general here.
I was shocked. Really high.
Really high, really high. We do have a lot of palliative care here and a lot of outpatient palliative care integrated. Early
71%
integrated. Yeah. I see Jennifer Temmel is on the paper.
71% of all of the patients received hospice services. 68 for those with performance status between 0 and 1, and like 55 for greater than 2. So, or 75% for greater than 2. So
yeah. And yet we saw differences. I mean, I think that there wasn't really differences in, I couldn't look at palliative care, receipt of palliative care actually, because we have so many palliative care studies here that people were getting palliative care through other studies. So it wasn't necessarily that they were referred by their clinicians independently. So I couldn't look at that as a factor in some of these end-of-life outcomes necessarily. I did look at clinician behavior because that is one of the hugely impactful things for a hospice referral. But no, I mean, I think that certainly the performance status findings, I think, are relevant in different places. Just thinking about, just have pause, when you're thinking about counseling a patient who has a functional status limitation, in recommending, or at least feeling like there's limited harm because they're better tolerated. Just thinking about the range of potential drawbacks, I think would be important. And then in terms of the end-of-life outcomes, I think that there is likely to be similar patterns of higher utilization given the kind of side effects, the just difference in overall mode of care, the insurance issue. I think the insurance thing is kind of one of the clearest things that probably drove this, kind of needing to continue with our standard year of medical care when somebody is not on hospice, if you're receiving these type of drugs, which would land someone in the hospital with any type of change in their symptoms. So I think that all of those things are likely happening elsewhere. And I'll just say too, we presented this work at the ASCO Supportive Care Symposium last year, and so many people came up and were kind of taking pictures and sending it to their colleagues, being like, "Oh yeah, I've seen this. I've been worried about this. I've been thinking about, I want to be able to talk with people. I know that it's different. Like they've seen that, their patients are not necessarily mimicking the clinical trials, and that there may be differences in the kind of end of life care they're receiving." So that was pretty validating to feel that at least anecdotally people felt like they had a shared experience.
Alex, did you have a last question, or?
That was my last question about the implications for clinical discussions. That's great. Yeah.
Well, Laura, I want to thank you for joining us today. I really appreciate it. Again, given everything that's going on here, how about we end with a little bit more of that depressing song, Alex?
The depressing song gives it away, right? We've been able to talk about a non-COVID topic for this amount of time, but where my head's
true that at least at this time, the majority of patients were taken care of. In fact, all of the patients on our palliative care service do not have COVID. That may change over time and may have changed by the time this podcast comes out. But we'll go back to this song that has the lyric, "I'll take a quiet life, a handshake of carbon monoxide." Which I want to think of just how grim that lyric is.
A heart that's full up like a landfill, a job that slowly kills you, bruises that won't heal. You look so tired, unhappy, bring down the government. They don't speak for us. I'll take a quiet life, a handshake of carbon monoxide, no alarms and no surprises, no alarms and no surprises, no alarms and no surprises.
Very nice.
Well, Laura, a very big thank you for joining us today. It's always great to see your face and hear you. Alex, it's good to see you greater than 6 feet away. And to all of our listeners, thank you for joining us today. And a big thank you to Archstone Foundation.
Thank you, Laura.
Thanks, guys. Great
Bye,
to see
everybody.
you.
Bye.
Take care.